Let us help our communities to stay safe and mentally healthy. In the pursuit of knowledge and healing, we must remain united and dedicated to the service of others.
Hello, everyone. My name is Dr. Anurita Kapur. My topic is on 5 crucial mental health illnesses. Mental health illnesses represent a major global public health challenge affecting individuals across cultures, socioeconomic groups, and life stages. According to the International Health Organizations, mental health disorders contribute significantly to disability, reduced quality of life, and premature mortality. Beyond individual suffering, mental health illness imposes substantial social and economic burdens, influencing productivity, healthcare systems, and family structures. Despite increasing awareness, stigma and misunderstanding continue to hinder early diagnosis and effective treatment. My academic study examines 5 crucial mental illnesses. I will be discussing those 5 crucial mental health illnesses that significantly affect individuals and society. Part 1 is Introduction Theoretical Framework as follows. First one is depression that can lead to major depressive disorder, which causes persistent sadness, loss of interest, fatigue, and difficulty functioning in daily life. Second one is anxiety disorders, includes generalized anxiety, panic disorder, and phobias, marked by excessive fear, worry, and physical tension. Third one is schizophrenia, a severe disorder affecting thinking, perception, emotions, and behavior, often involving hallucinations and delusions. Fourth one is bipolar disorder, characterized by extreme mood swings between depressive lows and manic or hypomanic highs. And the last one is post-traumatic stress disorder, PTSD, develops after traumatic events causing flashbacks, nightmares, and emotional distress. These conditions are selected due to their prevalence, severity, and profound impact on cognitive, emotional, and social functioning. Each disorder presents distinct clinical features while sharing overlapping biological, psychological, and environmental determinants. The primary objective of my discussion is to provide a comprehensive analysis of these disorders by examining their symptoms, causes, and treatment approaches. Emphasis is placed on evidence-based practices and contemporary clinical perspectives. Through a comparative and integrative framework, the discussion today seeks to highlight both the uniqueness and interrelatedness of major mental illnesses, thereby promoting a holistic understanding of mental health illness. Conceptualizing mental illness. Mental illness is broadly defined as a clinically significant disturbance in cognition, emotional regulation, or behavior that reflects dysfunction in psychological, biological, or developmental processes underlying mental functioning. Such disturbances often lead to distress or impairment in social, occupational, or other important areas of functioning. Modern psychiatry recognizes mental illness as multifactorial, rejecting simplistic explanations that attribute disorders solely to personal weaknesses or moral failure. Diagnostic classification systems such as Diagnostic and Statistical Manual of Mental Disorders, the DSM, and the International Classification of Diseases, ICD, provide standardized criteria for diagnosis. These frameworks facilitate consistency in clinical practice, research, and treatment planning, although they continue to evolve as scientific understanding advances. Part 2 is theoretical frameworks in mental health. Understanding mental illness requires integration of multiple theoretical perspectives. No single model sufficiently explains the complexity of mental disorders. Therefore, contemporary mental health research adopts a biopsychosocial approach. Biological perspectives framework emphasizes genetic vulnerability, neurochemical imbalances, brain structure, abnormalities, and neuroendocrine dysregulation. Research in neuroscience has demonstrated that alterations in neurotransmitters such as serotonin, dopamine, and norepinephrine play a significant role in mood and psychotic disorders. Genetic studies further suggest heritability patterns, indicating that individuals with a family history of mental illness are at increased risk. Psychological perspective. Psychological theories focus on cognitive, emotional, and behavioral processes. Cognitive models propose that maladaptive thought patterns, negative self schemas, and distorted perceptions contribute to the onset and maintenance of mental disorders. Behavioral theories highlight learned responses and conditioning, while psychodynamic approaches emphasize unconscious conflicts and early experiences. Social and environmental perspective. Social determinants of mental health include poverty, trauma, social isolation, discrimination, and chronic stress. Environmental stressors often interact with biological vulnerabilities, triggering or exacerbating mental illness. Cultural context also shapes symptom expression, help-seeking behaviors, and treatment outcome. Integrated biopsychosocial model. The biopsychosocial model serves as the foundational framework for this discussion today. It posits that mental illness arises from the dynamic interaction of biological predispositions, psychological processes, and social influences. This integrative model informs modern diagnostic practices and guides comprehensive treatment strategies that combine medication, psychotherapy, and social support. By applying this framework, consistently across disorders. The discussion ensures conceptual coherence while allowing for disorder-specific analysis. The subsequent sections will examine each mental illness through this lens, emphasizing how symptom, causes, and treatments intersect within broader systemic context. Following this introductory and theoretical foundation, my discussion proceeds as follows. Part 2 is major depressive disorder. Part 3, anxiety disorders. Part 4, bipolar disorder. Part 5, schizophrenia. Part 6, post-traumatic stress disorder. Part 7, comparative analysis, emerging treatments, and conclusion. Each of these sections will provide an in-depth examination of symptoms, etiological factors, and treatment modalities, supported by academic reasoning and clinical relevance. Part 2, Major Depressive Disorder, MDD, commonly referred to as depression, is one of the most prevalent and debilitating mental illnesses worldwide. It is characterized by persistent disturbances in mood, cognition, and physical functioning that significantly impair an individual's ability to perform daily activities. Unlike transient sadness, MDD involves enduring symptoms that persist for at least 2 weeks and often recur throughout the lifespan if left untreated. Depression affects individuals across all ages and is associated with substantial morbidity, increased risk of suicide, and reduced quality of life. The clinical presentation of MDD is heterogeneous, with symptom severity ranging from mild to severe. This variability reflects the complex interaction of biological, psychological, and social factors contributing to the disorder. Understanding depression through a multidimensional framework is essential for accurate diagnosis and effective treatment. Symptoms of major depressive disorder. The symptoms of major depressive disorder are typically categorized into emotional, cognitive, behavioral, and somatic domains. Diagnosis requires the presence of multiple symptoms that represent a change from previous functioning. Emotional symptom core. Emotional symptoms include persistent feelings of sadness, emptiness, or hopelessness. Individuals may experience a profound loss of interest or pleasure in activities once found enjoyable, a condition known as anhedonia. Emotional numbness and excessive guilt or feelings of worthlessness are also common, often disproportionate to actual circumstances. Cognitive symptoms, depression, significantly affect cognitive functioning. Individuals frequently report difficulties with concentration, memory, and decision-making. Negative cognitive biases such as persistent pessimism, self-criticism, and rumination reinforce depressive states. Suicidal ideation may occur, ranging from passive thoughts of death to active planning, representing a critical clinical concern. Behavioral symptoms manifest including social withdrawal, reduced productivity, and neglect of personal responsibilities. Individuals may exhibit psychomotor retardation, characterized by slowed movements and speech, or psychomotor agitation, marked by restlessness and irritability. Somatic and physiological symptoms. Physical symptoms are prominent in MDD and often lead individuals to seek medical rather than psychological care. These include changes in appetite and weight, sleep disturbances, insomnia or hypersomnia, chronic fatigue, and unexplained aches or pains. Such somatic complaints underscore the inseparable link between mental and physical health. Causes and etiology of major depressive disorder. Major depressive disorder arises from a complex interplay of genetic, neurobiological, psychological, and environmental factors. No single cause is sufficient to explain its onset. Biological factors, genetic studies indicate that depression has a heritable component, with first degree relatives of affected individuals at increased risk. Neurochemical theories emphasize dysregulation in monoamine neurotransmitters, particularly serotonin, norepinephrine, and dopamine. Additionally, abnormalities in brain regions involved in mood regulation, such as the prefrontal cortex, hippocampus, and amygdala, have been consistently observed. Neuroendocrine dysregulation, particularly involving hypothalamic pituitary adrenal HPA axis, contributes to sustained stress responses and elevated cortisol levels, which may impair neuroplasticity and emotional regulation. Psychological factors, cognitive theories posit that maladaptive thought patterns, such as negative self schemas and learned helplessness, increase vulnerability to depression. Early life experiences include emotional neglect, abuse, or loss, shape cognitive and emotional development, predisposing individuals to depressive reactions later in life. Personality traits such as high neuroticism, low self esteem, and perfectionism have also been linked to increased risk. Social and environmental factors. Social stressors play a crucial role in triggering depressive episodes. Factors such as unemployment, financial hardship, interpersonal conflict, social isolation, and exposure to chronic stress significantly elevate risk. Cultural and societal expectations may further influence symptom expression and help seeking behaviors. Treatment of major depressive disorder. Effective treatment of MDD typically involves a combination of pharmacological, psychological, and psychosocial interventions tailored to symptom severity and individual needs. Pharmacological treatments, antidepressant medications are commonly prescribed and include selective serotonin reuptake inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, SNRIs, atypical antidepressants, and tricyclic antidepressants. These medications aim to restore neurochemical balance and alleviate mood symptoms. While generally effective pharmacotherapy requires careful monitoring due to side effects and delayed onset of therapeutic benefits. Psychotherapeutic interventions. Psychotherapy is a cornerstone of depression treatment. Cognitive behavioral therapy, CBT, focuses on identifying and modifying negative thought patterns and behaviors. Interpersonal therapy, IPT, addresses relational difficulties and role transitions, while psychodynamic therapy explores unconscious conflicts and emotional experiences. Evidence suggests that psychotherapy is particularly effective in preventing relapse. Somatic and emerging treatments are in cases of treatment-resistant depression, somatic interventions such as electroconvulsive therapy, ECT, transcranial magnetic stimulation, TMS, and ketamine-based treatments may be employed. These approaches target neural circuits directly and have demonstrated efficacy in severe or refractory cases. Major depressive disorder is a multifaceted condition with profound emotional, cognitive, and physical consequences. Its etiology reflects the interaction of biological vulnerability, psychological processes, and social stressors. Advances in treatment underscore the importance of integrated care, models that addresses both symptoms and underlying causes. Anxiety disorders. Anxiety disorders constitute a broad category of mental illnesses categorized by excessive fear, worry, and behavioral disturbances that interfere with daily functioning. While anxiety is a normal adaptive response to perceived threats, anxiety disorders involve disproportionate, persistent, and maladaptive reactions that persist beyond appropriate contexts. Collectively, anxiety disorders represent one of the most prevalent groups of mental illnesses. globally and frequently co-occur with other psychiatric conditions, particularly depression. Common anxiety disorders include generalized anxiety disorders, GAD, panic disorder, social anxiety disorder, and specific phobias. Despite differences in symptom presentation, these disorders share underlying mechanisms related to heightened threat perception, emotional dysregulation, and avoidance behaviors. Symptoms of anxiety disorders. The symptomatology of anxiety disorders spans emotional, cognitive, behavioral, and physiological domains. The chronic nature of symptoms often leads to significant functional impairment. Emotional symptoms. Individuals with anxiety disorders experience persistent feelings of fear, apprehension, or nervousness that are difficult to control. Emotional hyperarousal may manifest as irritability, restlessness, and an overwhelming sense of impending danger, even in the absence of identifiable threats. Cognitive symptoms are cognitive features like that include excessive worry, catastrophic thinking, and heightened vigilance to potential threats. Individuals often overestimate the likelihood and severity of negative outcomes, leading to persistent rumination, concentration difficulties, and intrusive thoughts further impair cognitive efficiency and decision making. Behavioral symptoms. Avoidance is a hallmark behavioral feature of anxiety disorders. Individuals may avoid situations, places, or social interactions perceived as threatening, reinforcing anxiety through negative reinforcement. Safety seeking behaviors, such as reassurance seeking or compulsive checking, are also common. Physiological symptoms. Anxiety disorders are associated with pronounced physiological arousal. Common symptoms include increased heart rate, sweating, trembling, shortness of breath, dizziness, gastrointestinal discomfort, and muscle tension. Panic attacks, characterized by sudden episodes of intense fear accompanied by physical symptoms, may occur in several anxiety disorders. Causes and etiology of anxiety disorders. The development of anxiety disorders is multifactorial, involving biological vulnerability, psychological predispositions, and environmental influences. Biological factors. Genetic research indicates moderate heritability for anxiety disorders, with family studies demonstrating increased risk among first-degree relatives. Neurobiological models highlight dysregulation in brain regions associated with fear processing, particularly the amygdala, hippocampus, and prefrontal cortex. Neurotransmitter systems involving gamma aminobutyric acid, GABA, serotonin, and norepinephrine are also implicated. Additionally, heightened autonomic nervous system reactivity contributes to exaggerated physiological responses to perceived threats. Psychological factors. Cognitive behavioral models emphasize maladaptive beliefs and attentional biases toward threat. Individuals with anxiety disorders often possess heightened sensitivity to uncertainty and low tolerance for ambiguity. Early learning experiences, including overprotective parenting or exposure to fearful modeling, may reinforce anxious patterns. Personality traits such as behavioral inhibition and high trait anxiety further increase vulnerability. Environmental and social factors. Stressful life events, trauma, chronic stress, and social adversity contribute significantly to the onset and maintenance of anxiety disorders. Sociocultural factors, including performance pressures, social evaluation, and occupational demands, may exacerbate symptoms. Cultural norms also influence the expression and interpretation of anxiety related behaviors. Treatment of anxiety disorders. Evidence based treatments for anxiety disorders aim to reduce symptoms, modify maladaptive thought patterns, and improve functional outcomes. Pharmacological treatments. Medications commonly used include selective serotonin reuptake inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, SNRIs, and benzodiazepines. SSRIs and SNRIs are considered first-line treatments due to their efficacy and safety profile. Benzodiazepines provide rapid symptom relief but are generally prescribed short-term due to risk of dependence. Psychotherapeutic interventions. Cognitive behavioral therapy, CBT, is the most empirical supported psychological treatment for anxiety disorders. CBT targets distorted cognitions, promotes exposure to feared stimuli, and reduces avoidance behaviors. Exposure therapy, in particular, helps individuals habituate to anxiety-provoking situations and extinguish conditioned fear responses. Mindfulness-based therapies and acceptance-based approaches have also demonstrated effectiveness by promoting emotional regulation and present focused awareness. Adjunctive and preventive approaches. Lifestyle modifications, stress management techniques, and psychoeducation play important adjunctive roles in treatment. Regular physical activity, adequate sleep, and social support contribute to symptom reduction and relapse prevention. Anxiety disorders represent a diverse yet interconnected group of mental illnesses marked by excessive fear, and avoidance. Their etiology reflects complex interactions among biological predispositions, psychological processes, and environmental stressors. Effective treatment requires individualized, multimodal approaches that address both symptoms and underlying vulnerabilities. Part 4: Bipolar disorder. Bipolar disorder is a chronic and severe mood disorder characterized by recurrent fluctuations in mood, energy, activity levels, and cognitive functioning. These fluctuations typically occur in the form of manic or hypomanic episodes, alternating with depressive episodes. Unlike unipolar depression, bipolar disorder involves periods of elevated or irritable mood that significantly alter behavior and judgment. The disorder often emerges in late adolescence or early adulthood and tends to follow a recurrent course throughout the lifespan. Bipolar disorder is classified into several subtypes, most notably bipolar 1 disorder, bipolar 2 disorder, and cyclothymic disorder. Bipolar 1 disorder involves at least one full manic episode, whereas bipolar 2 disorder is characterized by hypomanic episodes and major depressive episodes. The episodic nature of the disorder poses significant challenges for diagnoses, treatment adherence, and long term management. Symptoms of bipolar disorder. The symptom profile of bipolar disorder varies depending on the phase of the illness and is typically categorized into manic, hypomanic, and depressive symptoms. Manic and hypomanic symptoms are manic episodes that are defined by sustained period of abnormally elevated, expansive, or irritable mood lasting at least 1 week. Symptoms include inflated self-esteem or grandiosity, decreased need for sleep, pressured speech, racing thoughts, heightened distractibility, and excessive involvement in risky activities, such as reckless spending or impulsive sexual behavior. Severe mania may include psychotic features, such as delusions or hallucinations. Hypomanic episodes involve similar symptoms but are less severe and do not cause marked impairment in social or occupational functioning. However, hypomania can still contribute to poor judgment and strained interpersonal relationships. Depressive symptoms. Depressive episodes in bipolar disorder resemble those of major depressive disorder, MDD, and include persistent sadness, anhedonia, fatigue, cognitive impairment, and suicidal ideation. These episodes often last longer and occur more frequently than manic phases, contributing substantially to overall disability. Cognitive and functional impairments are during periods of mood stabilization. Individuals with bipolar disorder may experience residual cognitive deficits, particularly in attention, memory, and executive functioning. These impairments can negatively affect occupational performance and social relationships. Causes and etiology of bipolar disorder. Bipolar disorder is among the most heritable psychiatric conditions, with a strong biological basis, complemented by psychological and environmental influences. Biological factors. Genetic studies reveal high heritability with first degree relatives of affected individuals at significantly elevated risk. Neurobiological research has identified abnormalities in neural circuits regulating emotion, reward processing, and impulse control, particularly involving the prefrontal cortex, amygdala, and limbic system. Neurotransmitter dysregulation, including alteration in dopamine, serotonin, and glutamate systems, contributes to mood instability. Circadian rhythm disturbances and sleep-wake cycle disruptions also play a critical role in triggering mood episodes. Psychological factors. Psychological models emphasize emotional reactivity, maladaptive coping strategies, and heightened sensitivity to reward and stress. Cognitive distortions related to self appraisal and goal pursuit may intensify manic and depressive symptoms. Stressful life events often precipitate initial episodes, particularly in genetically vulnerable individuals. Environmental and social factors. Environmental stressors such as interpersonal conflict, occupational stress, and substance use can precipitate mood episodes and exacerbate illness severity. Irregular daily routines and sleep deprivation are particularly potent triggers for manic episodes. Social stigma and lack of social support further complicate long-term management. Treatment of bipolar disorder. The treatment of bipolar disorder focuses on mood stabilization, relapse prevention, and functional recovery. Long-term maintenance is essential due to the recurrent nature of the illness. Pharmacological treatments. Mood stabilizers are the cornerstone of bipolar disorder treatment. Lithium remains one of the most effective agents for preventing both manic and depressive episodes and reducing suicide risk. Anticonvulsant medications such as valproate and lamotrigine are also commonly prescribed. Atypical antipsychotics may be used to manage acute mania or as adjunctive maintenance therapy. Antidepressants are used cautiously due to the risk of triggering manic episodes and are typically combined with mood stabilizers. Psychotherapeutic interventions. Psychotherapy plays a crucial adjunctive role in treatment. Psychoeducation helps individuals recognize early warning signs of mood episodes and improve medication adherence. Cognitive behavioral therapy, CBT, addresses maladaptive thought patterns, while interpersonal and social rhythm therapy IPSRT focuses on stabilizing daily routines and sleep patterns, lifestyle and psychosocial interventions. Regular sleep, structured routines, stress reduction, and substance use avoidance are essential components of effective management. Family focused therapy improves communication and reduces relapse risk by addressing interpersonal stressors. Bipolar disorder is a complex, recurrent mood disorder marked by extreme emotional fluctuations and significant functional impairment. Its etiology reflects strong biological foundations interacting with psychological vulnerabilities and environmental stressors. Effective treatment requires a comprehensive, long term approach integrating pharmacological, psychological, and lifestyle interventions. Part 5, Schizophrenia. Schizophrenia is a chronic and severe psychotic disorder characterized by profound disturbances in perception, thought processes, emotional responsiveness, and behavior. Unlike mood disorders, schizophrenia primarily affects reality testing, leading to a disintegration of cognitive and emotional functioning. The disorder typically emerges in late adolescence or early adulthood and follows a lifelong course marked by periods of exacerbation and partial remission. Schizophrenia is associated with significant disability, social isolation, and reduced life expectancy. Despite its relatively low prevalence compared to mood and anxiety disorders, its severity and chronicity make it one of the most burdensome mental illnesses globally. Symptoms of schizophrenia are that it is traditionally categorized into positive symptoms, negative symptoms, and cognitive symptoms, each contributing uniquely to functional impairment. Positive symptoms represent excesses or distortions of normal psychological functioning. These include hallucinations, most commonly auditory, in which individuals hear voices that others do not perceive. Delusions, defined as fixed, false beliefs resistant to contradictory evidence, are another hallmark feature. Disorganized speech and behavior, reflecting impaired thought organization, further disrupt communication and daily functioning. Negative symptoms. Negative symptoms involve reductions or losses of normal functions and are often more debilitating than positive symptoms. These include flat or blunted affect, social withdrawal, reduced emotional expression, anhedonia, avolition, and diminished speech output, alogia. Negative symptoms are strongly associated with long term functional impairment and poor quality of life. Cognitive deficits are central to schizophrenia and include impairments in attention, working memory, executive functioning, and processing speed. These deficits often persist even when psychotic symptoms are controlled and significantly interfere with occupational and social functioning. Causes and etiology of schizophrenia. Schizophrenia is widely recognized as a neurodevelopmental disorder arising from complex interactions among genetic, biological, psychological, and environmental factors. Biological factors. Genetic vulnerability plays a substantial role in schizophrenia, with heritability estimates among the highest of all psychiatric disorders. Neuroimaging studies revealed structural and functional brain abnormalities, including enlarged ventricles, reduced gray matter volume, and disrupted connectivity in neural network involved in cognition and emotion. Dopamine dysregulation, particularly hyperactivity in mesolimbic pathways, has long been implicated in positive symptoms, while glutamate dysfunction is increasingly recognized as contributing to cognitive and negative symptoms. Neurodevelopmental and prenatal factors. Prenatal and early developmental factors significantly increase schizophrenia risk. Complications during pregnancy, maternal infections, malnutrition, and obstetric complications may disrupt normal brain development. Early neurodevelopmental insults interact with genetic predispositions, increasing vulnerability during critical periods of brain maturation. Psychological and social factors. While schizophrenia is primarily biologically driven, psychological stress and social adversity influence symptom onset and relapse. Stressful life events, urban living, social isolation, and exposure to trauma can exacerbate symptoms. Substance use, particularly cannabis during adolescence, has been associated with increased risk in vulnerable individuals. Treatment of schizophrenia. The treatment of schizophrenia emphasizes symptom management, relapse prevention, and functional rehabilitation. Given the chronic nature of the disorder, long-term multidisciplinary care is essential. Pharmacological treatments. Antipsychotic medications are the cornerstone of schizophrenia treatment. First-generation antipsychotics primarily target dopamine receptors and are effective in reducing positive symptoms, but are associated with significant side effects. Second-generation atypical antipsychotics offer broader efficacy with improved tolerability and are commonly used as first-line treatments. Medication adherence is a major challenge, and long-acting injectable formulations are often employed to improve treatment continuity. Psychosocial and psychotherapeutic interventions. Psychosocial interventions play a crucial role in improving outcomes. Cognitive behavioral therapy for psychosis, CBTP, helps individuals challenge delusional beliefs and develop coping strategies. Social skills, training, supported employment, and cognitive remediation programs aim to enhance functional recovery. Family psychoeducation reduces relapse rates by improving communication and reducing expressed emotion within family systems. Community-based and rehabilitation approaches. Community-based care models emphasize social integration, housing stability, and vocational support. Assertive community treatment, ACT. Teams provide comprehensive multidisciplinary services to individuals with severe and persistent symptoms. Schizophrenia is a severe and disabling mental illness marked by psychosis, cognitive impairment, and social dysfunction. Its etiology reflects strong genetic and neurobiological foundations shaped by developmental and environmental influences. Effective treatment requires sustained pharmacological management combined with psychosocial rehabilitation and community support. Part 6. Post-traumatic stress disorder. Post-traumatic stress disorder, PTSD, can develop after experiencing or witnessing traumatic events, such as violence, accidents, natural disasters, or combat. Causes involve interaction of trauma, exposure, vulnerability, factors, history of trauma, limited social support, and changes in brain stress response systems. Core symptoms include intrusive memories or nightmares, avoidance of reminders, negative shifts in mood and thinking, guilt, detachment, and heightened arousal, such as irritability, hypervigilance, and sleep disturbance. Symptoms must persist and impair functioning to meet diagnostic criteria. Effective treatments combine psychotherapy and medication. Evidence-based therapies include trauma-focused cognitive behavioral therapy, EMDR, and prolonged exposure, which help people process memories safely and reduce avoidance. Medications, most commonly certain SSRIs and SNRIs, can reduce anxiety, mood symptoms, and re-experiencing. Prazosin may help with nightmares in some patients. Emerging approaches include digital therapeutics and neuromodulation, early intervention, social support, and a personalized treatment plan with a qualified clinician are key to recovery, and anyone with severe symptoms should seek professional help promptly. Finally, Part 7. Comparative analysis, emerging treatments, and conclusion. Comparative analysis of major depressive disorder, anxiety disorders, bipolar disorder, schizophrenia, and post-traumatic stress disorder share overlapping symptoms such as mood disturbance and impaired functioning, but differ in core features: persistent low mood, MDD, excessive fear and worry, anxiety, mood cycling, bipolar disorder, psychosis and thought disturbance, schizophrenia, and trauma-linked re-experiencing and hyperarousal, PTSD. Emerging treatments. Novel approaches include fast-acting antidepressants, for example, ketamine-based therapies, digital CBT, neuromodulation, TMS, DBS, long-acting injectables for psychosis, psychedelic-assisted psychotherapy, and precision psychiatry using biomarkers and genetics. In conclusion, across disorders, combining personalized medication, psychotherapy, and technology-enabled care shows promise for improving outcomes, and reducing relapse, emphasizing early diagnosis and holistic patient-centered treatment. Prioritizing mental health shows courage and wisdom. Seeking treatment promotes healing, balance, and resilience, improving life for you and everyone around you. Your time and openness in my discussion today will help you to detect, prevent, and treat these widespread challenges, which truly matters, helping reduce stigma and encouraging care for mental health and physical well-being. Please stay connected by subscribing to my American Global channel, the Dr. Anurita Kapur Channel, to gain knowledge from upcoming insightful videos on medicine, government, politics, diplomacy, intelligence, education, and entertainment in English, French, and Hindi. Thank you so much.